thank you all for having me today. It's really a pleasure to be invited here. So I thank Miranda and Elisa for giving us this opportunity to share what we've been doing in Colorado. So I am a genetic counselor that is situated at our Inherited Metabolic Disease Clinic at Children's Hospital, Colorado, and I'll explain how that role fits into our newborn screening program. So today we'll talk about the implementation of ALD newborn screening in Colorado as well as Wyoming. We were the 34th and the 35th state to implement newborn screening. So by no means leaders, more of slow to get the implementation going. I'll be able to share 2 years of our data as well as some of our experiences in our clinical setting, and then talk about how we're using this data and these experiences to continue quality improvements, both on the newborn screening side, but also in our role on the clinical side. And that will include next steps. So in Colorado and Wyoming, it is the Colorado Department of Public Health and Environment that screens all babies throughout Colorado with our birth prevalence of about 63,000, as well as Wyoming with their birth prevalence of about 6,000. Disorders come to be on our newborn screening panel through the typical process of the Board of Health approval. So it's a very collaborative approach that we have in Colorado, for which when a disorder is being considered for newborn screening, particularly if it's been added to the RUSP, we then are able to go with our health department as well as the clinical side, present the evidence to the Board of Health and get their vote of whether or not we can add that disorder to our panel. It has been many years since we've utilized a legislative approach, but rather this typical approach of going through our Board of Health. However, for our Colorado newborn screening program, they have always contracted out follow-up to the specialists. What makes us unique is that for Colorado, Wyoming, as well as other parts of things like Montana, western Kansas, western Nebraska, our Children's Hospital Colorado really serves as the main referral sources for all of these different areas of the region. So that means we have one metabolic clinic for multiple states. We have one cystic fibrosis clinic for multiple states. Endocrinology gets a little tougher, but for the most part, if there's a patient that needs to be followed for specialty care, they are going to be coming to our hospital. Hence, for Colorado Department of Public Health, they prefer to just provide us with a contract and money to conduct that follow-up. So once we were able to go through the Board of Health back in 2020 via Zoom, because it was the COVID days, we, as a clinical side, began to come together to really start our implementation of not only ALD, but we were also simultaneously working on implementation for Pompe and MPS 1. We're not the best at acronyms. We got a little silly with this one, but what stuck was what we called our Continue Work Group. It was the Colorado NBS Task Force instituting new uniform screening panels of errors of metabolism. It is messy, I apologize, but again, we've stuck that, this is our Continue group. And we have been meeting monthly since January of 2021, and our team included our geneticists, genetic counselors, such as myself and two of my colleagues with the metabolic team. We are lucky enough to have a biochemical lab geneticist with extensive experience for lysosomal diseases. We also invited our trainees, so these are our residents and fellows that soon will be geneticists, hopefully throughout different parts of the country, as well as invite our partners over at the Colorado Newborn Screening Program. That included the program manager for most of our monthly meetings, as well as his lab staff and his scientists that were being tasked with implementation. So again, similar to our Board of Health process, our implementation process is also very collaborative. What we lack in expertise in Colorado and a number of other points that we fall short, we actually gain with the level of collaboration that we've always had as the specialist team working directly with our newborn screening team over at the health department. As needed for this Continue work group, although it was being led by the genetics team at Children's Hospital, we would often bring in other specialists. So for ALD, for instance, we were able to start to develop relationships with neurology, endocrine, hem-onc, and radiology of what we envision newborn screening for ALD to look like. And so we had some goals of Continue, and these are goals I put up at the start of every year when we bring back together our Continue meeting and we start to invite new attendees, especially our trainees. We really want a goal of our algorithm to limit false positives and avoid those false negatives. But where we always want to keep the lens is what is happening for these families. We want to ensure that our follow-up and initiation of treatment is timely, and we want to ensure that families have access to the necessary biochemical studies and molecular studies with the least amount of burden for that family. That includes the psychosocial aspect of it, such as timeliness, the financial aspect of it, such as if genetic testing is needed for confirmation, that should be something that is taken into account and covered by our health department. We also think a little bit more about specimen collection. The reason I put up there a picture of Wyoming is because Wyoming and many parts of Colorado are extremely rural healthcare settings. Families might have to drive 1 to 2 hours to their nearest local community hospital that may have poked a baby 1 or 2 times in the last year. So we're trying to get these confirmatory laboratories done, and the option is either for a family to drive 10 hours to our center in Denver, Colorado, or go to their local hospital. We really try to utilize those local hospitals, but setting those hospitals up for success with getting those samples. So with that being said, if we're able to do things like a cheek swab or buccal swab for DNA, we're going to rely heavily on that versus a 3 to 5 milliliters of blood that we know will immediately result in families going through tremendous stress as their baby is getting poked by somebody with less experience in the peds setting. And again, we also want to think about that travel burden. We also wanted to ensure that our Continue work group was that multidisciplinary approach where we brought in and we relied heavily on all the specialists that are at our hospital, as well as ensuring that we also worked with families as needed to have them help us brainstorm. We also tasked ourselves with not only thinking about the short-term follow-up, but recognizing for ALD that we want to build in long-term follow-up and ensuring that just because we screen doesn't mean that we can't try harder and do better. And really, in a sense, what this was resulting in is equity for all the families in Colorado and Wyoming, not just for those ones that live local and happen to be within 20 minutes of our major medical center. So for the newborn screening table, we tend to all sit together. These look pretty similar of the phases of implementation, what we think about when we're starting to begin screening for a new disorder. I'll tell you that for some states, it looks like the top line, rarely. For other states like Colorado, it's sometimes that bottom line. But truthfully, we're going to strive for that middle option. That even though we're going to have some setbacks with our implementation of a new disorder, we hope that it's a relatively smooth process. I've been doing this since 2005, and so this was the first group of disorders for the metabolic team that we had implemented since 2005. So it had been a long time of very similar group of disorders for us to then think about how we can do things better. So for that ALD newborn screening follow-up algorithm, we very much recognize that in order to have a good screen, that we would have to utilize a tiered testing approach. For those that are not as familiar with newborn screening, what that means is that a certain percentage of babies will flag on that initial run, on that initial dried blood spot. However, the hope would be there be a more sensitive test that would take that large bunch of babies and get it down to a manageable group of babies that need confirmatory testing. So for ALD, as we've seen a lot of data about MSMS screening for C260, but also that lyso-PC is the way to go when we're really thinking about how best to determine which babies are at increased risk and need that additional studies. So that was a huge ask for us to tell our state that this had to be something that included a tiered process. We wanted to ensure whether that second tier testing would include biochemical markers, but also molecular. But our molecular, we had asked, came with a little bit of a twist. See, during these years of COVID, our state got a little bit more comfortable with doing genomic technology. However, they had never done anything more than targeted mutational analysis for things like cystic fibrosis. Although they had the equipment and could truly run gene sequencing, they had never done it on babies. They had done it on COVID variants. And so we very much recognize that, yes, while you might have the technology in-house to perform that, they were lacking the expertise that us on the clinical side felt comfortable with them utilizing. So we had asked what was realistic, and they shared with us that particularly for that additional tiered testing, that they would have to contract it out, which means that we had to then help them determine where best to send these specimens to. So, like many smaller state newborn screening labs, we rely heavily on kits and contracts with newborn screening companies. So for us in Colorado, we work very closely with Revity. Revity offers lyso-PC for C26, and so that was our option that we were given, that we could send our specimens after they flagged at the initial state lab out to Pennsylvania for that additional study. For molecular studies, we also look to see what our options were, and I have a little bit more slide on that. But with this proposed algorithm where testing was going here, there, and everywhere, we recognize that this would affect timeliness. And particularly for the genetic testing portion of ABCD1, we would need a new specimen, which would hinder turnaround time for these families. However, as genetic counselors in our clinic, we felt the ability to be able to talk to families directly over the phone, offer them pre-test counseling, but also for Invitae, they had another ability to offer free parental testing and cascade testing up to 150 days. That meant if we identified a proband in a family, we could act very quickly and ensure that the 3 or 4-year-old brother who wouldn't have had the opportunity to be screened for XALD could quickly get genetic testing. That for a baby girl identified on newborn screening, we could get parentals like that to be able to then work with the family to determine who in their family is at risk and go forward with cascade testing. We also had the ability, when utilizing a commercial lab like Invitae, that we could offer broader testing as needed. So if we did not find that a baby had an ABCD1 variant, but still had elevated very long chains, we were able to then reaccession the tests. So just give a call to the genetic testing lab and say, hey, we see you had negative testing for ABCD1. Would you be able to look at that broader, very long chain fatty acid panel that Ashley had just described as part of their process for workup? So this became very essential things that we asked our state lab to work on. So with ABCD1 sequencing, we wanted to make sure that this was available to all patients. In working in newborn screening and genetic counseling for many years now, I'll share with you that the ability to get genetic testing on a newborn is often hindered by the family, by the baby not yet being on the family's insurance. So we often, for our other disorders, would be able to meet with the family, let them know we needed to do genetic testing, and then said, hey, give us a call in a few weeks when your baby's been added to your insurance. Or that family would be tasked with paying out of pocket. So for both girls and boys, we wanted to make sure that our health department was footing the bill so that all babies could have access to genetic testing. We also, again, wanted to make sure that parentals, knowing that this would be part of the diagnostic process, would also be covered. We also wanted to recognize that given the number of private variants and variants of uncertainty, it became very important to us on the clinical side that we picked a reliable lab, one that we were used to working with, so that we could then have a great interaction with that particular commercial lab to be able to discuss what these findings were. So as I said, the biggest bonus though to us was the ability to expand that genetic testing as needed so that we could ensure that we were setting ourselves up with as much ability to identify a cause if a baby had an abnormal newborn screen, and not left families in what can often be described as frustrating and a long time frame until we got to the end of what was going on with those newborn screening results. So here's how we're doing. I'll be honest, I'm going to share some of the dirty laundry of Colorado of how this has been going, because it has had multiple hiccups. As much as I was hoping to show you all that middle line of some steps forward, one step back, there's been some times that we've had a lot of moments of frustration throughout these initial 2 years of screening. Our first ask is that the newborn screening result, particularly when additional testing was still pending, that the result would actually just say pending or incomplete. That's what's been happening for cystic fibrosis screening in our lab for the last 10 or so years. However, within the first few weeks of screening, and as we were waiting for that first batch of additional higher tier testing to be complete, we recognized that it was actually saying abnormal on the test result. And not only was it saying abnormal, but it was saying a value, and it was saying it in big, bold marking. And I'll show you a picture of that in a little bit. In the world of electronic medical records, families often have access to these results these days. So what do they see when they go to the hospital? You have a new lab pending, and you open up this long list of disorders, and at the very bottom, because that's where XALD falls on ours, a big, bold abnormal comes up. Unfortunately, a lot of families and primary care providers around our state had undue harm and anxiety because of how those results were being presented to them in their child's electronic medical record. As we're getting through that problem, fiscal groups at local state government don't always run smoothly. When there's turnover and there's remnants of COVID funding and other many issues, it turned out that some of our contracts, particularly for Revity, had hit a wall and hadn't been signed or renewed. So even though we were anticipating that this higher tier testing would be sent out at least once a week out to Revity, there was multiple times throughout our process where these weekly shipments almost turned into monthly shipments, and even a little longer because of a silly thing like a signature on a contract. Obviously, that wasn't the only delay was contracts, but rather the staffing at our health department would slide sometimes, that even though they had the intent to send these samples once a week, there would be multiple times where they were delayed just because it wasn't a priority to get these samples out for testing. I can tell you that because of the barriers and because of the data we were able to collect, they're now working on having that higher tier testing in-house, so we would hope for a much quicker turnaround time for these families. Additionally, once we got one contract worked out, Invitae was bankrupt, bought out by LabCorp, and now on the state paperwork, it still says Invitae, and so the health department hasn't been able to pay the bill because the company's now called LabCorp. So these are just the day-to-day battles in working in some of our smaller health departments around the country of how what should just be routine and consistently happening, we've seen barrier after barrier with a clean implementation for XALD. So these are our numbers as of January, mid-January or so. So we've screened in close to the first 2 years, 130,000. 1% of those babies did in fact flag on that first tier for an elevated C26 and were sent to Revity for the lyso-PC. Out of that 1%, there were 12 that were then reported to us at the clinic as having persistent elevations of C26 and requiring additional follow-up, where 99.1% of those 1,400 babies were actually cleared. When we take those 12 babies that were came to us, 3 of those have confirmed to have ALD, but if you look down and what's in red, we have identified 3 females, but have not yet identified any males during this process. We did not have anybody that fell in that indeterminate level, which in a way we were somewhat surprised, and I'm sure there will be times that we have some variants of uncertainty, some borderline very long chain fatty acids. We'll be talking a lot to those families about the gray zone, but for now we have not had that struggle. We did, though, in fact, find 3 babies that had persistent high elevations of very long chain fatty acids that were turned out to be in that Zellweger group, the peroxisomal biogenesis defect. And we did, in fact, also have a few just complete false positives in this process. So here's our data of how we're doing with that higher tier as a send out. We're able to look at the data because we have a wonderful graduate student who's been going through each batch and tracking the timeliness. But from that time that the newborn screening sample is collected, typically about 24 to 48 hours, to the time it makes it to Revity for that completion of the screening, we've seen ranges anywhere from 5 days upwards to 66. And just to let you know, if a sample is over 30 days old, it's rejected and we have to start over and get a new sample from that baby. Many of those longest stretches where there was not consistent specimens being sent out were actually during those 2 months of contract. Once the specimen is received at Revity, though, for that higher tier testing, their turnaround time is less than a day. They get them one day, they prep them, they will make a verbal call out if anything is abnormal that next day. Otherwise, the reports are available to us in a portal that we can then view. The newborn screening, though, to when that's resulted with all of these struggles, the average time is 15 days, which means for these babies, on average, by the time their newborn screening process is complete, and for those 99% of families that turn out to just having normal C26, it is 18 days of age for average. That is a very long time for a family to be in waiting and seeing abnormal test results, okay? We're not part of those families' lives yet because we're only contracted to call out those that is elevated. So it's very difficult because we get a lot of calls, even in recent weeks. I can say we've had 3 in the last week that's been a PCP, a family. They've seen an abnormal test result and they haven't yet seen the normal. That's what it looks like with the abnormal. You can see how that would stand out on a test result. It is very bold. It is meant to catch attention. That's not something that a family could brush over if they see those results by at the PCP's office or in their child's electronic medical record. Our plan had been at least weekly samples sending to higher tier. When we look at the average time, though, the average time is more like 10 days. So it's about a week and a half, it seems. It's not consistent. So in looking at the data, you can just see all the highs and the lows that are showing how many samples are in each batch. But you can also look at the bottom and see that there are some times where there are big gaps between when those samples are being sent. So at this point, I just wanted to share some cases because on the clinical side, I could share how some of these cases have gone. One of our first cases that we were called upon to offer consultation to and discuss genetic testing and additional biochemical studies was a healthy baby girl born to actually a first-time mom. The previous 2 pregnancies had ended in miscarriage. It was a vaginal delivery. However, when we hear how mom's birthing experience went, to say the least, it was really rough. She had had high blood pressure, postpartum hemorrhage, hypertension again, followed by another hemorrhage that required a DNC. So her first few weeks of life with her baby girl were miserable. At the very end, as she's getting through all that, we now have to call and explain that there's an abnormal newborn screen for C26. We're able to speak with the family, let them know that we do need them to come back in for some additional labs and collect that genetic testing for ABCD1. So the very long chain fatty acids were reported to us. We do utilize Mayo. The reason for us to utilize Mayo is clinically, we're very used to Kennedy Krieger. However, for a rural hospital in Wyoming or Western Colorado, we have much better success with being able to collect it if we use a larger reference lab. Okay, so that's one of those decisions we had to make early on is whatever plan we put in place would fit for all of our babies in our region. So with that sequencing, it looks very similar to the Invitae report again. But what we do find is that this little baby girl harbors a pathogenic variant in her ABCD1 gene. So the family comes into our clinic and we do what we usually do, which is to collect an extensive family history and talk through what these results mean. Mom is healthy, no concerns regarding her family history. Dad is also healthy, not reporting any concerns either at the superficial level. He shares that he's in law enforcement and that he's able to complete his daily tasks as a police officer, but has mentioned some fatigue. I was talking to our table a little while ago. I've worked in pediatrics for 20 plus years collecting family histories. Getting adult family histories still feels a little bit uncomfortable to have to go into that next level and start to really ask both mom and dad issues like urination, sexual dysfunction. But in bringing with this family, he was very noted when he entered the clinic room that his skin was quite tan. Okay, so immediately our red flags went up that while we're looking at mom and we're looking at dad, we think that this variant is coming from father. So with some extra questions and a little bit of prying, we do hear from him that he has excessive urination and some issues with incontinence. And again, as we're waiting for the labs, we felt very much the possibility that dad himself was having some adrenal insufficiency, and we sent him to our lab that day. And that's where he was at ACTH level. And then within 2 weeks, we did confirm that he carried the pathogenic variant. With that being said, what does that look like? Well, very quickly, we were trying to get dad seen by an adult endocrinologist, but we're also asking dad, who currently his employment requires quite extensive physical activity, strength, coordination, and such, that we want him to be seen by a neuromuscular clinic to talk through that evaluation. We also know with X-linked disorders, as genetic counselors, when we look at the statistics, that for every proband of an X-linked pedigree, we often are going to identify somewhere between 3 or 4 affected family members. At that point, we then turn our eyes to look towards the other members of the family and have to ask questions as if they're not local, how do we connect them to a genetic counselor that can offer them the genetic testing? Because of this Invitae genetics plan of 150 days, we're very quick to say, hey, we have this opportunity that if there's somebody interested in your family for genetic testing, we do have to hop to it and get those connections made so the family can utilize that service of getting that free and accessible genetic testing. And then, and I'm so changing my mind about this after hearing all of your stories, is we say there's no follow-up needed in our clinic for those girls. And that does not feel right. Doesn't feel right because what if in 6 months, 12 months, when the dust settles, there's more questions? We always say give us a holler, but families get busy. How often do they give us that call? But also to say, hey, just come back at reproductive age. Half of the pregnancies in the United States are not planned. And so just telling somebody this is something you could tell your daughter as they get older also doesn't feel right. And so we weigh the cost of coming in. Do we do telehealth? There's much better ways we can facilitate these discussions with these girls and make sure that we're not just diagnosing them, saying, well, you're not the target of newborn screen. The target of newborn screen is males that might require transplant or gene therapy, but rather think of some other ways that we keep them in our system to ensure that we are connecting with those families periodically. So case 2 got a little harder for us. This was a baby boy. I was actually away during this time, but he came along into this world at 37 weeks. It was a first-time pregnancy, again, for a mom. He did come into this world via an urgent C-section and wound up spending 9 days in the NICU. His APGARs were not good. These are measurements of how a baby's tone, breathing, color is doing at birth. We'd like to see 8s and 9s, not 1s and 7s. The baby after having a poor start, did spend those times in the NICU, required phototherapy, but in the end, the story we heard from the NICU team and the family is that he was eventually discharged and able to feed on his own, but he did fail his hearing screen ×3. At the time of the reporting of his elevated C26 from Revity, he was already 22 days of age. And so we proceeded in speaking with the family, coordinating those very long chain fatty acids, doing the sequencing. We do a lot of that on the phone with the plan of putting them in our clinic in about 2 weeks so that we can see them either via telehealth or in person to talk about those results. This was the family history. If I recall, Dad was an only child and there was nothing. Mom, as we're focusing on her for the X-linked, she had 9 healthy siblings. So it's kind of hard to say this looked like an individual that there was a family history of ALD. However, within a few days, you never want to get a phone call from Mayo. When they call you, it's not good. So when a genetic counselor calls you from Mayo, you know that something is quite abnormal. And sure enough, they called to say that the very long chains that were pending at Mayo were not consistent with the ALD, but rather looked more like a peroxisomal biogenesis defect. We were quickly able to switch gears, give our genetic testing partners at Invitae a call, and explain that, yes, we only checked ABCD1, but we want to expand to the whole panel now because we have suspicion. In the meantime, being completely transparent with the family, one of our fellows made a call to the mom, briefly talked about peroxisomal biogenesis defect, and then used the most terrible words of, please don't Google. I'm still working on what to say to a family, and I'd love to hear from the families in the room at the end of this talk. I now try to ask families, are you information seekers? How do you want to play these next few days? We're going to be waiting. Do you want me to give you reliable resources? Do you want me to give you a, quick what you need to know? If you are going to want to look at the internet and 2 a.m. feedings and you're going to open up your laptop, let me make sure at least that I give you reliable resources, that you're getting correct information. There are families that will be completely honest and say, I'm not going to look. Well, call me if you change your mind, because I want to make sure that when you go and type in the search bar, what comes up is reliable. But it's always a really difficult situation. However, we've heard it time and time in the newborn screening world that saying don't Google only equals one thing, Googling, okay? It's during that initial telehealth appointment that we got very quickly on the schedule, recognizing that based on biochemistry, this was likely a peroxisomal biogenesis defect, that the baby notably had multiple physical characteristics of such a disorder. And despite the history of being able to latch and feed, that was really far from the truth of how this baby was doing. They were pushing almost a month of age and had yet to regain birth weight. So there were a lot of red flags, which brings me to our other point in Colorado and Wyoming. We have rural health care. Many of our patients that we see don't have access to pediatrics. They might have access to APPs, so nurse practitioners and PAs, that again might only see a baby every few months, so they don't have that level of expertise. And so I never take it for face value anymore in talking to the providers when they tell me the baby looks beautiful, they look great, because until we start to get under that next level and ask some pretty basic questions like, are they back to birth weight? Like, not yet. Okay, that's going to give us a concern that we need to get this baby in sooner rather than later. So with those genetic testing results came back, this family had put themselves on the ALD journey. They were starting to connect with the ALD community where there's resources. Halfway through that process, there was a fork in the road and we had to say, nope, we're going this way now. That process, all in all, with our delays at a state lab, meant we did not get that confirmation until 2 months of age. So with that being said, this family struggled. We did a poor job of delivering that news. We didn't give them great information. Again, it was already a rough start in their journey into parenthood, and this only got worse. They were very frustrated that there was no treatment. that there wasn't great resources, that the baby was just not thriving. Within a few months of age, the baby wound up being an acute respiratory failure. And in more recent months has gotten a G-tube, has done a little better, but is honestly on hospice because that was the best that we could offer. But it was one of those struggles that things just didn't go as we planned. So as we take these lessons and figure out how we can get better, we've been doing a lot on the clinical side and with our state health department in developing a better short-term follow-up tool for tracking, but most importantly, data analysis. As I mentioned, I had a capstone genetic counseling student who, such a gift when those come along, that dug and dug and dug through all 1,400 reports to give us good, timely metrics that we can then take that data to our health department and say, things have to change. She also is in the midst of working on a parental survey to just understand from parents what this looks like when we are waiting on higher tier testing and they have not yet been connected to our specialist care, and what that frustration likely looks like and that waiting. We also had the benefit of working very closely with our health department on a long-term follow-up project funded through HRSA. We're now able to not only do this for ALD, but we are tracking clinic appointments across all newborn screening disorders in our electronic medical record system called EPIC. So every day, a dashboard runs at midnight, and we have real-time data for CF, all of our metabolic disorders, sickle cell, of who is still coming to care in clinic. And if needed, when they are no longer coming to care, we have what we call drill downs, which I'll show you our ALD one, where we can then pinpoint what's going on and if they're lost to follow up, or at least alert our schedulers that they need an appointment, whatever it may be. But we do have that benefit of that real-time data now throughout our specialist group at Children's. We're also working on adding monitoring labs and procedures in the coming year. And because of these efforts, our state is now funding a part-time, half-time, long-term follow-up data coordinator through our state contract so that these efforts can continue. In the meantime, our clinicians at Children's Hospital have been very busy building our ALD multidisciplinary clinic for our 0 boys that have yet to be identified on newborn screening. So, in the meantime, we're ready, and we are filling the clinic with some of our clinically diagnosed individuals and those that have been somewhat lost to follow-up post-transplant or have been being followed in different specialists are now coming for a one-day clinic appointment with our neurologist, geneticist, genetic counselor, endocrinologist, hemonc, radiology, and a nurse clinic coordinator that the health department is also paying a small fee for. For now, it's a quarterly clinic. We've had the opportunity with talking to some of the other multidisciplinary clinics around the country to develop what we want ours to look like. But our biggest win has been this development of our drill down in EPIC. This is mock data because we actually don't have any real patients to put in this database yet. But what we were asking our EPIC EMR to do is, for the most part, we're it. If you're going to get an MRI in Colorado or Wyoming, you're going to come to Colorado. If you need to see a neurologist, it's going to be Colorado. So we have the ability to be able to collect all this data on our patients, and we've developed the red light, green light, yellow light, which red light means you're overdue by today for an MRI. So if you were supposed to do it yesterday and didn't come in, today it turns red. 2 months prior to your MRI, it turns yellow. That signals to our nurse coordinator that she needs to reach out and get that MRI scheduled. Green means you've had one in the last 4 months and you're not yet ready to schedule or need one. Hopefully it takes away from that Excel spreadsheet, because we too were doing that with the Excel spreadsheet. But it also has the ability to track our endocrine labs, their next ALD clinic. So this is all being built out and ready to populate patients once we identify them. So here we are. Since I pulled the data in end of January, still don't have any boys. And so we're now over 70,000 boys since we began screening in February of 2023. We've lowered our first tier cutoff once already. There is debate of whether we can lower it again. Our state is in meeting with the roundtable yesterday. We do some unique aspects of screening that the other states looked at me with big wide eyes and said, why do you repeat things before you send them to higher tier? So some lessons learned already from just the last day. But we're only sending about 1% of our studies for higher tier testing, where other states have been cutting, having a floating cutoff and sending their highest 3%, highest 4%. So we are sending far less babies for that more sensitive test than most other states. So Joe is always one of the most helpful and biggest advocates for ALD newborn screening. And his scientist, Laura, have agreed to send us a number of specimens for our lab to run to just see where we're lining up, so that there will be some barriers to that study. We know that these C26 levels, according to Joe, with time, some of these specimens degrade with time, and those levels might be lower on first tier, but they should still hold up for second tier. So we're going to see how this goes. Some other folks also mentioned they might have some specimens for us. So this is the collaboration of newborn screening when you're the 34th and 35th state to go live. You actually have a lot of resources when things are not going as planned. And most importantly, we're going to be able to start that additional testing in-house, so that kind of 1% will hopefully be able to be closer to that 3 or 4% goal that us on the clinical side want to see. So with that, I just want to thank. Oh no, you're perfect.
Is this program totally funded by the state, or do you get federal funds and this?
That is a really great question. So
they just laid off in here 20,000 and
yes.
So speak with the lady.
So great question. Yes, I think we're all apprehensive in the world of public health right now. Our state is a fee for service. So a newborn screen costs about, gosh, I think we're at $118 for all of these services, right? But that money should be earmarked for mostly newborn screen. We do have some struggles that money often pays for some other things in a public health world. And so we don't always see all that money be directly returned. We don't get any money from our state budget. Again, this is a fee for service at our health department. But a lot of these beneficial projects, like our long-term follow-up project, all of these implementation of new disorder grants, they all were coming from groups like HRSA and CDC. And to be honest, for a state that is limping along like ours, those have been the biggest assets, because not only does it allow us to collaborate with everybody else in the newborn screening community, but it also gives us that push we sometimes need to say, okay, you haven't started screening for this. Here's a bunch of money. You have 2 years to figure it out. So when those funds start to go away, there will be ramifications at the state level. Adding new disorders will be tougher. It will make things harder.
My concern is the mentality is so personally affecting.
Yeah.
This is about it.
Yeah. And for instance, the Advisory Committee on Heritable Disorders in Newborn and Children that set up the RUSP, their meeting was canceled in February. We don't have one yet on the agenda. So there are struggles. So I just want to take a moment I have the most wonderful group of genetic counseling colleagues, Janelle and Leanne, that have, we work together as a trio. Our newborn screening program, they're aware when I dig in the data that we're going to find some shortcomings, and are always willing to circle back around. And they received the specimens from New York the other day, so now we'll wait and see what Greg and Corey are able to find for us. We also have great resource in Colorado, the Center of Public Health Innovation. It's a group of public health minded folks that really do a number of projects for newborn screening, and then of course our partners in New York State. With that, I'll take any questions from the crowd. Yes.
So I'll speak loud. I just want to make a comment about the Google.
Yeah, what are your thoughts?
So as a clinician, I think it's best, before you get up and Google the condition yourself, and then say to the family, most people will go to the internet to look up things. This is what I found. Oh, sorry. This is what I found. Or let me tell you what you're going to find if you go on Google, and let me prepare you for it. Because saying don't Google or believing someone that they're not going to Google, especially if it's Friday afternoon, is not fair to the family. And so I think it's best to just acknowledge that that's going to happen, acknowledge what they're going to find, and also send them to the right
Yes.
resources. I think that's just universal for everyone.
Jerry's got a question.
Yeah, so I actually have a statement. I don't know how many of the newborn screening follow-up care people are here and how much they realize. There is a very active parents group for Zellweger spectrum disorder, and it's the Global Foundation for Paroxysmal Disorders. We have also written guidelines for the management of paroxysmal disorder. So all of that information is out there. So I know it's a much more serious condition. It is often life-ending in childhood, but there are management guidelines out there. So, you know, we try not to just send them away.
Yeah.
Okay.
Good, I'm seeing. I likewise just have a statement. I know how difficult it can be to come up here as someone who also is a GC at a referral site for the newborn screening for ALD and kind of air that dirty laundry, as I think you said. But I really appreciate that you did it because it's gotten my mind spinning about some of the own problems that we face, albeit with a very different protocol for newborn screening. And that's how we learn. So I really appreciate you just taking the moment to say, here's where we struggled, here's where maybe we haven't succeeded, and hopefully your multi-D team will truly collaborate like you hope. I just
Yeah.
wanted to thank you for that.
You're welcome. I will say our state does collaborate. So thank you guys. And it's not the first time we had to air our dirty laundry. This has happened before. We have ups and downs. State government is no easy place to work for most of our scientists and lab techs and program managers. It's demanding. It's 6-7 days a week. It's no matter what, you're going to get those results out, but with that come a lot of ups and downs. So if we don't go looking and asking the right questions, then we don't know. We could all put our blinders on and say, well, we're screening, that should be good enough. But it's the families that are waiting at times for weeks and talking to them and hearing their concerns. It's tough. This is such a tough process when a family is alerted about a screening result. And I appreciated for Ashley just even saying waiting. It's, you know, every time on her screen, what caught me is wait. And it is a lot of that waiting. So we can minimize as much as we can of that. So for these families, they get an answer as quick as we can.
Best of luck.
So, yes.
So since we've kind of learned that
Yeah.
it's very important, what steps do you plan on taking to kind of change that mindset or protocol?
Because there's 3 of us genetic counselors, we tend to drive what happens in our clinical setting. So for us, I think it's just us saying, hey, we're going to meet with you and we're going to do a 6-month follow-up, or we're going to do a 12-month follow-up, because that's what we've done for some of our other disorders that have required less intervention. We've never just said, see you, okay? We've done 3 to 5 years. Well, 3 to 5 years, we recognize somewhere around 2 years is when we lose contact with them. So I think it's just us as a team saying this isn't fair to these families, that we delivered a very unexpected diagnosis. It has ramifications for other members of the family, but if we lose touch with that baby, then we can't follow up to know whether the affected family was able to get into the adult services they need. Did that actually happen if we don't see them? So at the very least, maybe it'll be starting simple and just doing a follow-up at a year, and then gauging with each family what they want. If a family wants to come, I think we're always willing to see them. But if we're just saying we're done, that doesn't feel great either.
Hi, I'm a genetic counseling student at UConn. I was just curious if you are anticipating the continuation of the free cascade testing at Invitae, which is now LabCorp. I wasn't sure if with that transition, if they were going to keep doing it.
I call it returning 150 days cycles and we get the result.
I anticipate it's going away. Like every time.
For now, we still
Yep. And we've seen it before with our free panels and such. We have a resource and then we don't anymore. We have some backup plans in place right now that we're still brainstorming because, we convince our state lab, if you pay the bill and we just put in their coding, we could order the test. It was great. So you had to know it had to end at some point. But it was, when I saw my Google search come up that Invitae had declared bankruptcy, I was like, yep, too good to be true. Thank you all.